first and foremost thing in this particular challenge, apart from that difficulty in the anesthesia and surgery for this rectifying or repairing this fistula. Okay, so when you talk about the anesthetic challenges in a repair of tracheoesophageal fistula, because it is done in the neonate, all the problems associated with neonatal anesthesia, you have to at least make a few mention of it. Like they have low blood volume, they are more prone for hypothermia, they can go in for what is called flip-flop circulation. Have you heard of that? What is flip-flop circulation?
I don't think so, sir.
Don't know. Okay, so you have to read about all that. So that
Okay,
is the
sir.
first and foremost challenge. Second challenge is already the lungs would have been contaminated. It's either, as you said, either a gastric aspiration or a blind upper pouch producing aspiration of the pharyngeal and salivary secretions. So the placement of the endotracheal tube to occlude the fistula and do an effective ventilation of the lungs, the most important challenge in this. That can be achieved by several methods, as you said, by
Fogarty's
bronchoscope.
catheter and using the bronchoscope.
You can use a rigid bronchoscope, you can use a fiber optic, or if nothing is available, you can do a blind advancement into the right main bronchus and auscultating and finding only air entry in the right side, then slowly withdraw the tube and then find both lungs getting ventilated and pull it up and see when there is a leak is occurring and then place it just distal to the fistulous opening so that both the lungs are equally ventilated. So that is a blind technique. It's also possible in experienced hands. But once you have fixed that, the tube should be securely fixed in the same position till the surgery is over. And while the surgeon is trying to repair that, he may push the tube out or pull it down. So displacement or even extubations have happened. So you have to be very vigilant throughout the procedure till the fistulous communication is ligated and separated. And so that is another great challenge in this particular case. Is there any special tube to aspirate the contents of the upper blind pouch, which is called esophageal atresia? You said about nasogastric tube. Is there any
Yes.
special tube that is available? Any name for that? Ammu or Venkateswar Rao? Is there any special tube devised by a surgeon to aspirate the upper pouch? Try to find out and tell me in the next class.
Sure, sir.
Okay. So we'll just see a presentation on that. You have covered most of the points that are there in that, but I would just like to add a little more on that. Okay. Invisible?
Visible, sir.
Yes, sir.
Okay. So the first and foremost challenges in the anesthetic management of a tracheoesophageal fistula patient is pertaining to neonatal anesthesia. And if there are any associated congenital anomalies, that may also be an additional challenge. And the airway and ventilation challenges. These are the three primary things that you have to write. And usually it may be associated with fractal abnormality, which are the components all of you know. And during the embryologically, during 4th week of embryonic life, trachea is differentiated from esophagus. So if there is an incomplete separation from the trachea from the floor of the foregut, tracheoesophageal malformations are formed. So these are all the associated anomalies that are there in the vacral, vertebral anomalies, cardiac, and perforatanous, renal agenesis. So if all these things are there, you have to be much more careful. So gross classification, as you rightly said, there are 6 varieties or A, B, C, D, E, F types. And this E variety, which is called the H type, is very, very common because it looks like the alphabet H. So there's a communication, but this is the most easiest to prepare because once you just clamp this communication, you have to just dilate this area may be little stenosed, so that can be dilated with dilators later on, and this will be the easiest method. And this is non-communicating. This is the most difficult one because you have to pull the stomach up and then pull the pouch here and prepare them. And in this, the upper pouch is only in communication with the trachea, so mostly the salivary and pharyngeal secretions will go into the lung. Whereas in the C type is the most one which gastric contents go into the lung. So this causes more morbidity. And the D type, there is a communication from the pouch above as well as from below. And this F type is very simple. Actually, there is no fistula at all. There is only a narrowing of the esophagus. And the diagnosis is not easily diagnosed prenatally, though polyhydramnios is there because of usually the child swallows the amniotic fluid. When there is a esophageal fistula or atresia, it is not able to swallow, so amniotic fluid accumulates and produces polyhydramnios. And when the child is born, it has excessive salivation and choking during feeding. And confirmation of presence of atresia is by a suction catheter. So if it is the type A only, you get that. And where you pass the suction catheter, it coils down and does not go for more than 10 centimeters. And chest radiograph will find out where the catheter is there, if the blind upper pouch in type A defect. So you can see there is the coiling of the esophageal tube in the pouch here. And pre-op problems frequently associated with aspiration, pneumonia, and sometimes sepsis also can happen if it is too much delayed. An esophageal tube passed into the upper pouch is suctioned intermittently using low pressure suction. Fluid and electrolyte imbalances are corrected and sepsis is managed with antibiotics. Sometimes it may be necessary to perform a cervical esophagostomy for drainage of the upper pouch and place a gastrostomy tube for enteral feeding. So this also, all these things will be required if the child is in very poor, as you said, weight is not adequate and you want to improve the weight, then you have to do all these things. All oral feeds are stopped and neonate is kept in upright position, and intermittent suctioning of the upper esophageal pouch is performed to decrease the accumulation of saliva. A preoperative echocardiogram is necessary as cardiac defects such as ventricular septal defect and tetralogy of Fallot are commonly associated. And this aortic arch anomaly is another important thing. What is the importance of this aortic arch anomaly? Grishma.
So,
You said this surgery is performed in right lateral thoracotomy, isn't it?
yes, sir.
Patient is placed in left and right thoracotomy is done. So
Yes, sir.
sometimes if the aortic arch, instead of taking the turn like this, it takes opposite side, then you have to do a left thoracotomy, not right thoracotomy. So you have to assess the aortic arch also with a echo.
Okay, sir.
5% of the patients have reported to have right-sided aortic arch requiring a left thoracotomy. So this is how the arch will appear. Instead of going to the left side, it will be turning to the right. So in vactral anomaly, if there is a sacral dimple present, it is beneficial to obtain a lumbar ultrasonogram, because if you are planning for a caudal catheter postoperatively, there may be some associated spinal cord anomaly. So this is the dimple that usually you see above the anal margin. So if it is present, caudal is contraindicated. Should not do that. Renal ultrasound should be obtained to rule out hydronephrosis or other renal anomalies. Coming to the intraoperative management, detailed intraoperative plan must be developed that takes into account surgical technique, airway management, and potential for blood loss, because they are neonates and have a low blood volume. all these things. So a detailed discussion with the surgeon is very important. Two main surgical approaches are open thoracotomy and thoracoscopic approach. So advantage of thoracoscopy, it is minimally invasive, reduction in musculoskeletal sequelae such as winged scapula, which will happen if you do an open thoracotomy. So the intercostal nerves are cut, so the scapula becomes winged later on. And disadvantages of thoracoscopy are desaturation due to lung compression, reduction in venous return as a result of direct compression of vascular structures such as the inferior vena cava and the right atrium. And carbon dioxide absorption results in hypercarbia and acidosis, which may be poorly tolerated by the neonates. In open technique, left decubitus position for a right thoracotomy approach. This is how the patient is positioned. This is how the incision line will be. For a right-sided aortic arch, a left thoracotomy approach is preferred, as I said earlier. A total open one-stage repair where the fistula is ligated and the esophagus is primarily anastomosed. This is the one-stage repair. If fistula is at the level of the carina, one lung ventilation may be necessary, predisposing the infant to hypoxemia, hypercarbia, and developing an increase in pulmonary vascular resistance. And sometimes cervical approach is used for high fistula, which is situated above thoracic level 2. So you can see this is the right shoulder of the child. This is the face. So they make a cervical incision, pull out that, and then try to correct it. So anesthetic management, routine monitors, EKG, blood pressure cuff, end-tidal CO2, temperature, and one pulse oximeter if no ductal dependent cardiac lesion is present, but two must be there. So if congenital anomaly, if there is a duct dependent circulation, you have to have two or one each on each limb. Arterial line should be in the left limb for continuous hemodynamic monitoring and analysis of blood gases. Two peripheral IVs should be placed. Cross-matched blood should be available in the operating room. If there is a need for parenteral nutrition post-operatively, central access must be obtained. Goal during induction is to intubate the infant with minimal distension of the stomach. That is the major goal for us. Awake intubation is our old technique. Now it is totally become obsolete and not recommended by all the pediatric anesthesiologists, as the rise in ACP and intraventricular hemorrhage, especially if the baby is a premature baby, then intraventricular hemorrhage is very, very common. General anesthesia via inhalation route while maintaining spontaneous ventilation, and then have a surgeon to perform a rigid bronchoscopy. This rigid bronchoscopy is to determine the exact location and size of the fistula and to assist with placement of endotracheal tube distal to the fistula and above the carina. So this is the picture where the child has been induced by spontaneous method with inhalation agent to the deep level, and then the surgeon does a bronchoscopy and tells you where exactly the location is. If fiber optic bronchoscope is available, after ET tube placement, fiber optic scope can be used to properly position the ET tube. The carina is identified and the ET tube is pulled back with fiber optic bronchoscope inside the ET tube until the fistula is visualized, and then the ET tube is advanced just distal to the fistula. So the FOB is used as a stellate and you have a vision. So you first go beyond the fistula, then pull it up, and once the fistula is identified, you just push the tube alone and withdraw the FOB and place it correctly. And when the fistula is located at the level of the carina, a Fogarty catheter can be placed into the fistula and occluded, and inflation will be help to close that and prevent gastric aspiration. So this is how the Fogarty catheter looks like, and there will be a small balloon. So what is this catheter commonly used for? What is the use of this Fogarty catheter? Is it for tracheoesophageal fistula, or this gadget belongs to some other specialty? Kirishma.
Sure.
Fogarty catheter is actually what also called an embolectomy catheter. Okay, so they usually pass it for removing an embolus. Okay, so this will be, the bulb will be deflated, the cuff will be deflated, and it will be passed through a femoral vessel, especially the lower limb embolus if it is there. Then they will thrombus if it is there, they will pass it beyond the thrombus, inflate the balloon, and pull it out through a small opening that is made in the vessel. So it is a embolectomy catheter, it is called.
Okay, sir.
Ways to confirm placement of endotracheal tube in good position just distal to the fistula are: first thing, auscultation of breath sounds. Right or left main stem bronchus intubation with gradual withdrawal until bilateral ventilation is established, ideally 1 centimeter above the carina. Then you can take a chest radiograph, you can do an ultrasound, and if a gastrostomy is present, bubbling versus lack of bubbling is when the tube is above the or below the fistula. So when the endotracheal tube is above the fistula and if still the fistula is there, when you ventilate, if there is a gastrostomy tube, you will find air bubbles leaking out. But once the fistula is close by the tube wall, then there won't be any leak. So if gastrostomy is present, it is easy to find out whether the tube is beyond the fistula or not. Now, gastrostomies are not routinely performed because gas from the trachea may bypass the lungs and exit through the stomach, leading to loss of effective ventilation. And bronchoscopy may not be available following inhalation induction, spontaneous ventilation. You can routinely, surgeon may perform a gastrostomy. This is then followed by endotracheal intubation under deep inhalation technique and using muscle relaxant if necessary with gentle manual ventilation. Previously, they said no manual ventilation should be done, but gentle manual ventilation is now accepted. The initial gastrostomy allows gas to be vented out and prevents gastric distension and minimizes the risk of aspiration. That is the advantage of gastrostomy. Once the airway is secured and appropriate intravenous and the arterial access is obtained, the patient is positioned in the left lateral decubitus position and pressure points are carefully padded. Accumulation of blood and secretions in the endotracheal tube can lead to airway obstruction, may require frequent tracheal suctioning during surgery. And surgical airway manipulation and collapse of the upper limb due to retractors can cause marked hypoxemia. So on and off, you must tell the surgeon to release the retraction and allow the lung to expand. So close communication with the surgical team is paramount importance, and the intubation equipment should be readily available in case of accidental extubation and the need for emergent reintubation. Post-op considerations: after TO surgical repair via thoracotomy, full-term neonates without comorbidities can be extubated post-operatively. But infants with other congenital anomalies or infants who require more complex repairs have to remain intubated for a few days in the neonatal intensive care unit. An esophageal catheter is used for suctioning and carefully taped and sutured in place so that you don't have to repass it. Regional anesthetic techniques like cardally placed epidural catheters can be used for pain management. Intercostal nerve blocks can be performed by the surgeon when you request them. And opioids can be given carefully and paracetamol safely for neonates because they are more sensitive to opioids. And complications are: early postoperative complications include esophageal strictures or anastomotic leak, and some leaks may require surgical treatment, so re-exploration may be required. And strictures may be dilated with multiple balloon dilators later on. And a rare complication is tracheomalacia. And the success rate after surgery depends on, as he said, birth weight more than 1,500 grams, no major cardiac anomaly, 95%, 98% success, with less than weight less than 1,500 with or major cardiac anomaly, any one of them present, 82%. If both are there, then it is 50%. So there's a good chance of salvaging these babies. So you can take all precautions and try to get a normal child back. And the surgery is very rewarding. It is done properly at the correct time. Okay.
Thank you very much, sir.
Thank
Any
you.
doubts from the students or questions?
Thank you, sir.